Joining us now is Dr. Marie Bernal, Chief Officer for Scientific Workforce Diversity at the National Institutes of Health. In her role, she leads NIH's efforts to promote diversity, inclusiveness, and equity throughout the biomedical research enterprise. Dr. Bernal, thank you for joining us today.
Thank you for having me.
It's a pleasure. So, tell us a little bit about your role as a head of diversity at the NIH. It seems like it's a really long-term perspective to diversify the scientific community. How do you go on your day-to-day in improving diversity in the community?
Yes, the role of Chief Officer for Scientific Workforce Diversity is a big role. We lead the thought in the science of scientific workforce diversity with the goal of making sure that in a data-driven fashion, we take advantage of the full array of talent that's out there to optimize creativity and innovation in science. So yes, it's a very big role. We work across NIH with all of the institutes and centers and offices. We work outside of NIH, partnering with other federal agencies, academic institutions, foundations, because we're all in this together. It's really important that we take advantage of all that talent if we're going to maintain our leadership role in science across the globe.
Now, we know that sadly the scientific community has not always valued diversity as much as it should. How long has the NIH been leading on this point, and how did it get to the point of understanding the value of diversity in the scientific community?
So NIH has been in this space for a while, and there have been a couple of punctuation points that have accelerated our focus. For instance, this role of the Chief Officer for Scientific Workforce Diversity was developed after a report in the journal Science in 2011 that showed that when you looked at the success in getting what's called an R1 equivalent grant, the brass ring that every scientist strives for, that there were disparities based upon race, ethnicity, for African Americans, Blacks, Hispanics, Latinos, Asians. However, when you controlled for all sorts of factors, English as a first language, where everyone trained, where everyone was working, all sorts of other things, there was a persistent disadvantage found for African American and Black scientists. So Francis Collins, NIH director, turned to his advisory committee and asked for recommendations for what should be done. And one of the things that was recommended was the development of this role of a Chief Officer for Scientific Workforce Diversity. So I'm very privileged to succeed Dr. Hannah Valentine, the first COSWID, as we call it. She came on board in 2014. She retired from NIH at the end of September in 2020, and I've had the privilege of first being the acting and now the permanent COSWID. So that was one punctuation point. And along with that, a lot of wonderful programs developed to try to help enhance pathways for people to be successful in science. The second punctuation point was 2020, the pandemic, with the disproportionate morbidity and mortality for communities of color, African Americans and Black, Hispanics, Latinos, American Indians, Alaska Natives, and others. Further punctuated by the videotaped murder of George Floyd. And it made us, along with everyone else, stand back and really examine what we're doing. And it led to NIH officially unveiling, after lots and lots of discussion and internal work, officially unveiling in February of this year an initiative that we call Unite, to end structural racism. We're looking systematically at what we can do internally for NIH, what we can do externally for the biomedical workforce, and what we can do in terms of enhancing research so that we can get rid of that excess morbidity and mortality that was seen during the pandemic.
So we're going to get to an audience question in a second, but I want to rest on that point you made about the punctuation point of 2020. What role does scientific diversity play in increasing community involvement and community trust from minority communities in the scientific community? I mean, we know Latino communities have a lot of misinformation to deal with, and Black communities have a lot of historical perspective that makes it very hard for many Black Americans to trust the medical community specifically. So how does this diversity increase that trust?
There's just no question that when you have diverse scientists at the table, number one, they're going to think in broader and different perspectives about the things that are necessary to come up with the answers scientifically. And sometimes there are things that you would never have imagined would make a difference for a community that that person from that community will bring forward. It's also very clear that the people who are most interested in looking at questions about health disparities, health equity, often are people who may come from those diverse backgrounds. So they come with a different perspective and different focus of the science that's really important. And then finally, when it comes time to recruit people into scientific studies, over and over again, it becomes evident that people who are willing to volunteer really like to be able to interact with someone that they see as being like themselves, someone who understands cultural mores, differences, etc. So, and at every step, it's important to have that diversity, whether it's getting a representative group of people involved with a research study or coming up with a great idea. When it comes to what's happened with the COVID pandemic, it has been just further magnified that you must have those diverse perspectives and those diverse individuals working with the community. I think the data shows that people are most likely to trust what their primary provider says is a good thing to do. There's no question that primary providers who come from underrepresented racial and ethnic groups tend to be more in those communities. And so that's what you need to do. And NIH, through many of the initiatives that were established during the pandemic, not to say the pandemic is yet over, but since it's gotten started, has done a lot of outreach along those lines.
Since you mentioned clinical trials, we have an audience question on that topic from Michael Causey.
Hi, my name is Michael Causey. I'm the editor-in-chief with the Association of Clinical Research Professionals. Our 13,000 members represent the people who design and conduct many of the clinical trials here in the United States and around the world. My question is for Dr. Bernard at NIH, and really for anyone who'd like to answer, but I'd like to hear what you think about the importance of diversity in the clinical trial workforce and the patient population, and some steps we might take to improve both. Thank you very much.
Yes, thank you for that question. This has been something that's been near and dear to my heart throughout my career, and it is absolutely essential that you have diversity among the people who are designing clinical trials, diversity among the people who are going out into the field for recruitment, and that you have diversity among the participants in the study, because otherwise the data that is derived from it is not necessarily truly applicable. We have great examples of that when it comes to years ago when it was only men who were involved in clinical studies. And then as women became involved in clinical studies, it was discovered that there were differences in biology. We are seeing that in things like the field in which I was most immersed prior to taking on this role. I was deputy director of the National Institute on Aging, that there are differences in the manifestation, for instance, of Alzheimer's disease by race, ethnicity, and by gender. And if you don't have those individuals involved, you're not going to see those things. You're not going to come up with treatments that are really appropriately applicable. I'll just put a shout out there as well that you need to make sure that people are represented by age. Many a clinical study ends up, for instance, for the older adult segment, focusing on people who are 65 to 70 and very, very healthy. And yet the data are supposed to be applied to people who are 80, 85, and maybe not quite so healthy. Those people need to be included in clinical studies, just as children need to be included in clinical studies if the disease entity is something that applies to children and you want to extrapolate the findings.
Dr. Bernard, it's been such a pleasure chatting with you. Thank you for joining us.
Thank you.